Hi, everyone. Welcome to our presentations today regarding the Behavioral Wellness Award for Public Health. I just want to say thank you so much to the Boulder Rotary Club, in particular the Behavioral Wellness Committee, as this is such an important opportunity for our students and for our school to be collaborating with you. Well, what is the Behavioral Wellness Award for Public Health? Well, the purpose of this award is to encourage student focus and scholarship on innovative public health responses for addressing mental health consequences of the COVID-19 pandemic in the state of Colorado. And ultimately, we're looking to, this was the brainchild of Gary, Kahn, Hans, as well as Lori Crane and myself, and we wanted to get students to engage in real-world experiences and organizational initiatives. So it was just a really good opportunity for Boulder Rotary Club and the School of Public Health to come together. So what this resulted in actually were 4 students who received awards for the projects that they're working on. And the first one is our honorable mention awardee, who is Megan Watson. Megan is a Master of Public Health graduate in Population Mental Health and Wellbeing. And the title of Megan's project was Identification of Barriers and Facilitators for Functional Neurological Disorders Clinic Implementation. Our third place awardee was Kristen Young, who's a Master of Public Health candidate in Population Mental Health and Wellbeing. Kristen's project is titled San Luis Valley Behavioral Health Group Community Needs Assessment. Our second place awardee is Jennifer Villalobos, and Jennifer is a Doctor of Public Health student in Community and Behavioral Health. And her title of the project she's working on is Latinx Caregiver Perceptions and Cultural Differences of a Mindfulness Intervention Among Informal and Formal Caregivers. And then finally, our first place awardee was Laura Kirkbride, who's a Master of Public Health candidate in Population Mental Health and Wellbeing. And Laura's project is titled Using Wearable Technology to Help Facilitate Positive Mental Health in Employees of the Department of Medicine at the University of Colorado Anschutz Medical Campus. Today, the order of our presentations will be Megan Watson first, followed by Kristen Young and Laura Kirkbride Romeo. Okay, thank you. I'll let you take it over now. Awardees. Our honorable mention awardee is Megan Watson, and she's a Master of Public Health candidate in Population Mental Health and Wellbeing. And the title of her presentation, or the title of her project at the time, was Identification of Barriers and Facilitators for Functional Neurological Disorders and Clinic Implementation. She has a little bit of a different title coming up, and so I'll present that to you too. Our third place awardee was Kristen Young, who's also a Master of Public Health candidate in Population Mental Health and Wellbeing. And Kristen focused on the San Luis Valley Behavioral Health Group Community Needs Assessment. She's going to focus on substance use needs assessment during her presentation. The next awardee was Jennifer Villalobos, who is a Doctor of Public Health student in Community and Behavioral Health. And her project focused on Latinx caregiver perceptions and cultural differences of a mindfulness intervention among informal and formal caregivers. And then finally, our first place awardee was Laura Kirkbride Romeo, who is a Master of Public Health candidate in Population Mental Health and Wellbeing. And Laura's presentation, or Laura's project, was focusing on using wearable technology to help facilitate positive mental health in employees of the Department of Medicine at the University of Colorado Anschutz Medical Campus. So with that being said, I actually have a lineup of presentations here, but I do want to stop sharing my slides and ask if anyone has any questions about the scholarship, or the award, and if there's anything that I can answer regarding that now.
I think we're good.
I think you're good.
Yeah,
okay.
Good.
Okay. With that being said, we have Megan Watson first. The title of her presentation is "Why is it difficult to treat functional neurological disorders? The barriers explained." And Megan, can you share your screen? Are you able to?
Yeah, let's see. All right. Get in here. We'll do kind of like the old-fashioned way. Let's see. Right. Here. How does that look? You seeing the screen?
Yeah.
Perfect. All right. Well, thank you so much for allowing us to come and present. My name is Megan. I have since graduated with my MPH, so very excited to announce that. And your support of this project was just integral. And so thank you so much for that. So I focused on why it's difficult to treat functional neurological disorders and the barriers explained. Just to produce some content or some context, excuse me, functional neurological disorders are a group of disorders that produce a wide variety of symptoms, anything from limb weakness to blindness to movements to seizures. And the etiology of these is absolutely neurological, but the treatment is behavioral health. And so unfortunately for these patients, there's an average 7-year delay to diagnosis because this diagnosis sits right where neurology meets psychiatry. And so they have to get diagnosed by a neurologist, but then they actually get transitioned. They say they do. They don't actually, but they get transitioned to a behavioral health specialist to actually conduct the work of, reversing the symptoms and recovery. And so my capstone research aim was to qualitatively assess community behavioral health providers' perceived barriers to the utilization of evidence-based treatments for patients with FND. And to do that, I recruited 18, but 11 ended up being able to participate within my capstone period between June and July of 2021. I used a convenient sample. I will admit I am the program manager of the FND clinic at the University of Colorado, so I have a very specific interest in this. And so a lot of these providers we had actually already established with or share mutual patients with. It was really just the actual time frame that they were able to do these interviews with me that was the barrier. Hopefully, we're planning to engage more to be able to increase our sample size for the purpose of publishing. But for each of the participants, I collected their demographic information, and then I ran through a semi-structured interview of 10 questions, asking them all about their understanding and perceived barriers of treating FND in the community. And then obviously transcribed, reviewed, did all of the good qualitative, good clinical practice methods. I applied 2 analyses, and the reason for this is because the first analysis is what's called phenomenological. Oh, I did it. I'm worried. And what that analysis allows me to do is take a step back because I am so close to this disorder, the patients and these providers. I really wanted to provide, do an analysis that I was able to decrease the amount of bias that I came to the project with, and then obviously really looking at it from a 30-foot view and say, what are the themes, that we're seeing within these behavioral health communities that they're really just not treating this disorder. They don't understand the disorder. And so for anybody in my industry, everybody knows that there's a lack of education when it comes to this disorder for behavioral health clinicians. There's a huge communication breakdown from diagnosis to actual treatment. There's a lack of time, of course, and parity to treat behavioral health for all behavioral health disorders, obviously not just this one. And then the diagnosis itself is actually extremely difficult to treat for a behavioral health clinician who doesn't understand the diagnosis because they have these physical manifestations, of this trauma and behavioral health concerns that they have. And so it's actually very scary for a behavioral health clinician that doesn't understand the diagnosis. And so they often get put into the emergency room, and it's a whole vicious cycle. And so from those themes, I was actually able to apply a second analysis by mapping it onto the CFIR framework, which I'll show in my next slide. But the goal of that was to be able to produce domains for the purpose of implementing this treatment in the behavioral health or community behavioral health setting. So here's my very complicated graph here, I guess. But it was a consolidated framework for implementation research. And like I said, the purpose of this is to really identify the places that we would need to work on in order to be able to implement this in the community setting. Our clinic at the University of Colorado is actually only one of 5 in the nation that treats this disorder, despite the high prevalence. And so this work is incredibly important for us to really be able to understand where those barriers are and where, is it actually the intervention that's difficult? Is it the outer setting, or is there just really a lack of, resources for these providers? Is it a culture piece? This patient population is highly stigmatized. Or is it, just the lack of knowledge, of the providers? Like if they did know, would they treat them? Possibly. And so then also the process, because we're one of 5 clinics in the nation that treats this, it shows that we really need like a champion. We need these people who, high level degrees, possibly things like that, to be able to really engage the people who have the money, right? And have the interest in being able to serve and, fund the treatment of this population. And so implications and future directions, we found that the barriers were obviously bidirectional. Environment is, influencing the actual individual providers to be able to do this work. And then the providers are influencing the environment by really not having time, unfortunately, to devote to this patient population. And so as of right now, excuse me, I am working with another MPH classmate. Her name is Teresa Mesher. She's going to be working on this as a unaffiliated coder for publication of this paper so that I can make sure that everything is unbiased, and then hopefully publish this in I'm hoping like an epilepsy and behavior journal or like a neurological based journal. But otherwise, that's my project. So thank you so much. Really appreciate your support of this program and happy to take any questions.
It's impressive, Megan. Very impressive what you're doing.
Thank you very much. Appreciate it.
Sorry, I had it muted here.
Yeah, you missed the applause.
We'll have to go back and dub that into the recording. So. I was just wondering what your next step is after you have publication. Are you presenting this at a professional meeting? Do you have anything lined up like that yet?
Absolutely. So I'll be presenting the abstract of this paper in a poster to the Functional Neurological Disorder Society meeting in Boston in June. And then additionally, what this work has done, as well as a few other pieces that we're working on, is actually created the foundation for a community educational effort that we're doing with the clinic, going into the community and actually educating those behavioral health clinicians on the diagnosis and different pieces of that. And we actually have our first community night on March 31st, where our providers will be going into the community virtually and really answering any questions that providers, behavioral health providers have, and just making sure that they understand the diagnosis and know either where to refer patients to or, get information and education on the diagnosis.
Do you know a faculty member named Jim Grigsby by any chance?
It's not coming to mind.
He's in the psychology department now, but he used to be in the Department of Preventive Medicine as well, and in the Department of Medicine. He's a professor in the Department of Medicine, and I think he's still an associate director of the health services research or something like that. So and I think this, he's at that intersection, and he's also the discoverer of Fragile X ataxia syndrome and a lot of neuromuscular diseases. He's worked on studies of that. So he crosses the boundary really well that you're trying to, I think you guys need to talk. And so
That sounds, yeah.
If you'll get my contact information from Danny, I'll get you guys in touch, okay?
I think that'd be great. Thank you so much.
Sure. Thank you.
Of course.
All right, if we're ready for our second presentation, I have the opportunity to introduce here Kristen Young. Kristen's presentation is the San Luis Valley Behavioral Health Group Substance Use Needs Assessment. Kristen, you can go ahead and share your screen.
Thank you so much for having me here today. I'm excited to share my project with you all. Thumbs up if you can see the correct screen. Excellent. So I did my practicum on the San Luis Valley Behavioral Health Group Substance Use Needs Assessment. And my preceptor was Dr. Jamie Puma, and I also had the opportunity to work with Dave LaRocca, who's a PhD candidate with the Colorado School of Public Health and Rocky Mountain Prevention Research Center. Okay, so excuse me. So the San Luis Valley Behavioral Health Group aims to provide access to quality behavioral health services that enriches lives and promotes wellness. To support this mission, they provide substance use services, including individual therapy, group therapy, medication assisted treatment, or MAT, and dual diagnosis therapy. The purpose of the needs assessment was to determine substance use and existing treatment options within the San Luis Valley. The needs assessment report was meant to support the development of a maintenance plan to serve the needs of the community related to substance use. So there were 3 steps in the needs assessment. All was done remotely due to COVID. The first one was to collect secondary data around substance use, socioeconomic data, and anything related that could help uncover any social determinants of health that need to be addressed within the Valley. I also developed a stakeholder interview guide and conducted interviews, as well as surveys with the San Luis Valley Behavioral Health Group clients on their perception of services. I compiled the data, did qualitative and quantitative analysis on the results, and recommended some evidence-based practices as they move forward with any action to improve the outcomes of the community. So just an overview slide of what I found during my secondary data collection. 26% of the San Luis Valley, which is here in the dark blue, also known under the Health Statistics Region 8. So it compiles Alamosa, Conejo County, Castillo County, Sawash County, and Mineral County. And so they're all lumped together under HSR 8. So 26% of residents live below the federal poverty level. 13% of them are uninsured, and 45% utilize Medicaid. It's also known as a health professional shortage in a medically underserved area. And then unfortunately in 2020, the rate of age-adjusted rates per 100,000 of drug overdose was extremely high. So 52.8 was the rate compared to the Colorado average of 24.8. And so this is the trend from 2009 until 2020. As you can see, it was up for a little bit in 2015 and 2016. It evened out with the Colorado state average and has increased since. And as you noticed in 2020, there was a giant increase upwards. So the need for this assessment was always needed, but in 2020 and the COVID pandemic really highlighted this need. Something also to point out during my data collection is that the transportation in San Luis Valley is not the best. It's hard for people to access transportation, including to get to medical appointments. And so after I did the secondary data analysis, I did interviews and then also surveys. Some high overview results for the interviews. Some major gaps and barriers for treatment within the Valley, as I talked to 18 different stakeholders, was that there's a huge need for local intensive treatment, a more robust workforce, and then also an improvement in transportation. Some facilitators to treatment that were found was that there's several options for outpatient services, especially MAT throughout the valley, which is great. There's also like a community that's very invested in substance use outcomes and improvement, so that will be really instrumental going forward. So with the COVID-19 impact, there's definitely been an increase in isolation. And for anyone who knows San Luis Valley, it's kind of geographically isolated as it is. It's surrounded by 3 mountain ranges. And so COVID-19 really amplified that. So a lot of substance use has increased, including polysubstance use, depression, and anxiety. But on the flip side, there were a lot of opportunities to engage with people virtually for telehealth. As I talked to the stakeholders, one of the questions was, if you had a magic wand and could bring any resources to the valley, what would you bring? So local intensive treatment and recovery, education, and prevention programs were their top wish. And I also had the opportunity to do surveys for the clients of SLV Behavioral Health Group. I provided the survey remotely and they distributed within their clinics. And so this sort of got to what their perspective is or was on substance use services, treatment, and factors that impact those. So for service utilization, most people, 66%, do like group or individual counseling, 49% do MAT, and then 35% do support groups. An in-demand service that 35% of the respondents indicated was that they wish they had an intensive outpatient service. There's not one that exists in the valley, and if it does, it's only limited to criminally involved patients. And so the top beneficial factor for them to access care, particularly to SLV behavioral health, was that they indicated that they have a very supportive staff. And the most challenging factor was transportation. One of my contacts, SLV behavioral health, he's an addiction medicine provider, and he also has an MPH. So it was great to work with him to think of it in a medical treatment and also a public health lens. So this is kind of the spectrum of services in the valley as related to the ASM levels of care. So prevention and early intervention do exist in the valley, but they definitely need improvement. Level 1 or outpatient services such as MAT and counseling, SLV does a great job of providing that service throughout the valley thanks to grants and community leadership. Level 2, 3, and 4, that's anything more intensive, and these don't exist in the valley, and if they do, it's for a very small percentage of people who are criminally involved that are mandated to do it. But even then, it's very sparse compared to other areas. Most of the time for those who need more intensive inpatient services, they need to go to Pueblo or Colorado Springs, and that definitely impacts their at-home life. They're completely taken away from home and come back to the same sort of environmental exposure, anything else that kind of get them back into the bad habit of something that they were trying to get away from. So overall key findings that I found with my assessment, there's, like I said previously, there's lots of MAT locations throughout the valley. There's a lot of community leadership and people who are invested and have good programs for harm reduction. There has been an increase in substance use. However, there's been also an increase in the virtual services. So that's kind of the flip side of COVID. Other socio determinants that really highlighted that there needs to be improvement in order for people to really engage in treatment and sort of have a baseline of life really is, transportation, economic stability, housing. There's been an increase in mental health, polysubstance use. There also really needs to be a more robust workforce. A lot of people might train in the valley, but then leave to like Denver or Colorado Springs just because it's such an isolated rural area. Also, prevention, early intervention should definitely be improved in the Valley. And so just some top recommendations that I found from my needs assessment was, focusing on those socioeconomic factors that could really improve their overall quality of life, mental health, workforce, different intervention programs, and then also an increase in local intensive and recovery options. And so I also provided this SCM model for them to kind of look at it, not just far as like a treatment, but also to, address societal, community, and interpersonal factors, which all definitely influence substance use. I also provided some other programs that they could look into that are a good match as far as diversity, rural areas, and then anything else that would be evidence-based for substance use. Okay, hopefully I didn't do that on time. Any questions?
Yes, that was brilliant. I have a question.
Yeah.
It was just so fast because you covered so much territory. Would it be possible to get your PowerPoint or your presentation in the wording?
Oh, definitely, yes. I'd be happy to.
Maybe Gary, you can facilitate that somehow.
Yeah, we're recording this, Bobby, so it will be up on the Rotary channel. I'll send a link out to the membership of the committee, so you'll be able to get that, to watch this again if you want to. Is that what you need?
I wanted to read it.
Yeah, that's fine.
That's how I absorb things.
I do too, I understand. Yes, I can definitely provide the presentation.
Yeah, so if you guys have scripts or something you want to forward to me through Danny, then we'll get them out to everybody.
Great.
Kristen,
Thank you.
can you hear me?
Yes.
Well, I hope you can hear me. Say, I noticed the upward curve there in 2020 and the pandemic going into 2021. Has it leveled it off, or is it even worse because of 2021? Do you have any data on that? Because knowing how remote San Luis Valley is and Alamosa, I'm wondering if it's gotten worse rather than even any leveling off.
I would speculate that as well. I haven't, I wrapped up this project end of November of 2021, but I have also been curious as well. So I would imagine it's gotten worse.
Good job. Thank you.
Yeah, thank you.
Thank you.
Right. Thank you, Kristen. That was wonderful. And last but not least, we have Laura Kirkbride Romeo. Today, Laura's presentation is on using wearable technology to increase mindfulness, a quality improvement project.
All right. Hello, everyone. I'm going to share my screen. There we go. Okay. Hello again. Let me actually move back here real quick. So again, my quality improvement project was using wearable technologies to increase mindfulness. And please excuse my mask. I'm currently at work and can't take it off. So please let me know if you can't hear me or if I'm not being clear. First things first, though, I really wanted to start off by thanking the Boulder Rotary Club for your interest in important topics such as mental health. While most of us know that mental health is extremely important and as important as physical health, it's because of organizations like the Boulder Rotary Club taking interest in things like this that we are able to break down barriers to care, especially in mental health. So really, really, really thank you. Thank you for this. So on to a quick recap. I worked with the Wellness Initiative in the Department of Medicine here at Anschutz Medical Campus, and we were looking to mitigate burnout and other negative mental health outcomes in the department because we had a survey in 2020 that was showing that that really needed to happen. So we used mindfulness and the resiliency theory to inform our intervention. And if you remember, we used 2 wearable technologies. You can see them right here. We have the HeartMath Inner Balance and the Muse 2. These devices help coach the individual.
Laura, sorry to interrupt. We can't see your slides moving forward.
Oh,
We
okay.
only see your title slide.
Sure. I'm gonna stop sharing and then reshare, because hopefully that will change everything.
It might be the enabling.
There
You go. I think
There it is. I had them on 2 different screens. I didn't realize, so thank you. So this was my quick recap slide. And then our 2 wearable technologies, like I said, we have the HeartMath Inner Balance and the Muse 2. They coach you into more mindfulness state. As you see here, the Inner Balance is worn on the ear and it measures heart rate variability. And the Muse 2 is worn around the forehead and uses 7 different measurements in brain waves to help coach you into mindfulness. I put together a pre and post survey. Individuals could rent these devices, quote unquote, rent the devices for 6 weeks. And we asked them to do a voluntary pre and post survey. And the information that I'm going to be showing you on the next few slides is based on what we found in those surveys. So a quick orientation here, the arrows on the left indicate with the name of the construct being measured, indicates the scoring. So in this case for depression, a higher score would indicate that the individual would be most likely needed to be screened for depression, and decreasing scores decrease that likelihood. So our entry scores for this, and we're looking at depression in the Patient Health Questionnaire 2 survey, we started with a score of 2.125, and then at exit, we decreased to 0.875. For the Generalized Anxiety Disorder Scale 7, a survey consisting of 7 questions, we had entry scores of 6.25, and exit scores decreased to 3.5. For the UCLA loneliness scale, this is looking at loneliness, we had entry scores of 4.625, and then it decreased to 4.5. And then lastly, we looked at mindfulness itself, and in this case, a higher score would indicate a more mindful state. And we had an entry scores of 3.075 and exit scores of 3.75. So we saw an increase there. We looked at acceptability of the devices as well. And in this question, how comfortable are you with mindfulness at this time? We had over half say somewhat to very comfortable, which was really, really a cool finding. And then lastly, did that change because of the device? 87.5% said yes. So that was a real fun finding as well. So quick discussion, the trends are showing good signs. While we didn't have enough people do the entry and exit surveys to convey statistical significance, we are seeing these good trends in the right direction, which is why we wanted to try this out in the first place. Participants overall really enjoyed their experience. We had some free answers, and people were saying how this really helped their mindful state and just their mental state in general. In the future though, more mindfulness training definitely needs to happen. If any of you are familiar with mindfulness, it's an easy concept to speak about, but in practice, it can be extremely hard. So the more training that we can provide, the more likely we'll have even more success in this intervention. And then lastly, more mindfulness device training. The devices themselves are pretty intuitive, but there was a little bit of troubleshooting issues, and so just having that a little bit more training on that might be helpful for our participants. But in conclusion, I'd like to say one thing about this project. It is an individual intervention, and while the individuals who participated in it really benefited from it, I don't want to say the problems, but in order to help with healthcare worker mindset and mindfulness and well-being, there needs to be system level changes and leadership buy-in. So while we can implement these individual focused interventions, we really do need to start looking at also systems level changes and also leadership buy-in. And then this is a quick acknowledgement. I worked with some incredible individuals on this project, and I would not have been able to do it without them. So thank you, thank you, thank you. And then again, Boulder Rotary Club for having this award and shining light on the important, extremely important topic of mental health. And that's it. Thank you.
Very good.
Thank you.
Thank you very much. That was great. I have a question. Do the companies that provided the devices that you used have any research like this to back up their devices? And if so, are they, do you consider those, you know, like controlled trials of any kind?
Okay, yes, that is an excellent question. And yes, absolutely. So the HeartMath itself actually has done trials in hospital settings to see if they have improvements in various areas, I should say. And they have, I think they do have randomized control trials showing that there are improvement. The Muse 2 does not have any specifically in hospital settings, but they have done research in high stress jobs. So you could potentially say that's kind of the same thing, although it would be really cool to see if the Muse 2 could do something in hospital settings. Regardless, they also showed improvement in positive psychology within those groups. So they do, both of them have a ton of research to support that they actually work. But in the populations that I'm looking at, only the HeartMath has done any work with hospital workers.
Other questions?
I do have a question. Are you familiar with the Calm app?
Yes.
They are doing some, a lot of research into putting their programs into corporations, and if they're at the testing level at this point. Are you familiar with it?
I'm not peripherally I am. I've just heard about it, and but most of my experiences using Calm myself are just word of mouth from other people mentioning it.
Yes. So what do you think about the potential for device mediated mindfulness training versus some of these apps that are getting a lot of traction now, it seems like, because of, you know, I think it's as much because of the inability of the community to respond with providers that they're trying to take up some of the slack. And it does seem like some of these apps are actually able to do that. Is that something that you might look at in terms of comparison with the device-based approach?
Yeah, that actually is a good question. So it's all technology, right? And so I think it really is dependent on the user itself. The devices themselves are expensive, and so in order for you to get one yourself, you would have to, you know, purchase it for anywhere from $160 to $200. So that could definitely be a barrier, but, you know, hopefully in this case, what one of our goals is to potentially have the Department of Medicine subsidize that cost for individuals who would be interested in it. Or, you know, just have a library where people can check them out. I don't think that this is any way going to replace mental health help. I think it would enhance positive, like I had said before, enhance positive psychology, but would work better as maybe a way to, like I had said, enhance what you are already doing for yourself in the mental healthcare realm, if that makes sense. So just as a way to enhance, but not necessarily as a fix for negative mental health states.
From your work, do you have a hunch, if not a specific character trait or screening trait that you could define as who these are most effective for?
Oh, that's a really good question too. So the demographic information that I collected was not specific enough to that, but as a hunch, as you and I just speaking to each other, it definitely would need to be a self-motivated individual, because this is a choose your own adventure. No one is telling you you have to use these devices, but the more, as in mindfulness itself, the more you practice it, the more it will help you. So if you are and we have in the medical field, as you I'm sure know, a lot of self-driven individuals. So that's why I think it worked out so well, but you would definitely need to have that go-getting attitude.
Thank you very much. So, I would just like to say that we couldn't have hoped for a better outcome in terms of the quality and of the projects, as well as the talks you guys have delivered. It's just really impressive, and it's a testament to the quality of the school and the academic program. So we are delighted that we've been able to connect with you, and hopefully we'll continue to do that. In fact, Danny, I wonder if you might say a little bit about what the scholarship committee has recommended in terms of ongoing collaboration here on this type of project.
Yeah, so the scholarship committee is very excited about just continuing to move forward with potential funding of additional projects with students. These were great projects. We have a clear connection with population mental health and well-being, which is a concentration in our Master of Public Health program. Our recommendation is to move forward with mental health focused, if that, and in particular, there's been discussion about focusing on adolescents as well, but taking a little bit of a switch and not just having COVID specific projects that people are looking at. Again, we found that that's very important, and we want to open the door for that opportunity, but we want to make it a little broader. So, and there's been discussion about all the ACEs, so the adverse child issues that have been brought up with a number of researchers within the school and students projects that they're focusing on. So those adverse outcomes of childhood are really important as well. So we've kind of gone down the path of hoping that you all would consider funding again a round of projects for students that continue to focus on mental health, but having a bit broader focus.
Yeah, and we have discussed that at our committee meeting, and everybody seems to agree that's a valuable thing to do. And just in terms of the one thing that we're kind of dealing with now in terms of budget issues, what's the timing that would be best for you to know that there is actual, because we talked about potential for having 2 rounds of this, I think one in the summer, one in the fall, if I'm not mistaken.
Well, most of our students are deciding on their capstone and practicum projects, which a lot of the applicants for this particular award previously were based on those projects. So we have quite a few students who actually take capstone or practicum in the summer. So the submission of their materials for those courses actually happens, oh gosh, probably mid spring, so maybe beginning in March. They're really focusing on what their topics are going to be for the summer classes. And then in the fall, they're deciding in the middle of the fall semester, so probably around October, what their projects will be. So ideally, it's kind of a mid-semester call for projects, because then We're hoping to also entice students to consider focusing on mental health projects because of this award that would be available. Not that students need incentivizing like money to do great work like this, but it really helps with their project if they need some support for participants or additional materials or anything like that as well. So.
Okay, great. So if you'd like to know at least for the next round by March, is that?
Yeah, we would need to know prior to that because we put a call out. So as long as we could submit a call to say, yeah, maybe mid-March or so, if we could put that application call out there to be able to fund for summer projects, that would be ideal. Yeah.
Okay, and those would be due when?
Probably sometime before the beginning of the summer semester. So our summer semester begins in June, beginning of June. So we would want to know prior to that.
Okay, and then for the next round, what would be the timing?
Ideally put an application call out about mid-October so that there could be funding available for the beginning of, we could have, it depends on if we went fall or spring. So if we wanted to do a fall call, then, but I would say do a spring call because there's a higher number of capstones and practicums in the spring. So I would say a mid-October application call for the second one so that there could be funding available for the beginning of the spring semester, which starts in later January.
Okay, great. That's very helpful. Thank you.
You bet.
And so once again, I want to thank all of you for doing this work and for sharing it with us today. Just fabulous work and presentations. And if any of you want to stay on for the Rotary meeting, that'll start again at a quarter after 12. And we're going to sign off of this Zoom call now. And then, is Bobby still on there? Bobby, are you still there? Okay. So, yeah. So we'll be signing off of this Zoom call, and we'll a new one will start with a different Zoom link. Do you guys have that?
I can send that. I'll send an email really quickly here with that.
Okay, and yeah, there'll be a different Zoom link, but feel free to join on that talk if that appeals to you. If you could just send them that newsletter with the description of the talk, they can decide whether that's something they like to do or not. Thanks so much, everybody. We'll be in touch.
Thank you.
Thank you.
Thank you so much.
Thank you.
Kid.
Student that's going to probably present.